having a fireside chat on healthcare, cybersecurity, and compliance. So successfully adapting to the new proposed HIPAA security rules, right, and federal regulations. So we may discuss whether that will actually happen or not, and if so, what it might look like. I think there's varied opinions on that. But we had a little bit of HIPAA history this morning. I thought I'd just kind of set the table, if you will. Right, so back in, 30 years ago, 1996, August of 1996, HIPAA came in, right? And it stands for the Health Insurance Portability and Accountability Act. And it was really put in place, right, to allow employees to move from one company to another, make sure that their health records could follow them through that, and that they'd be able to maintain insurance. So it really had nothing to do with cyber, right? And I think 7 years later in 2003 is where they said, wait a minute, we're now exchanging data and healthcare is not so good about protecting data, right? So they put in some data control regulations in place, right? And so that lasted for a while. And 10 years later, right, 6 years later, I'm sorry, then they came out with high-tech. So they're like, okay, so we asked people to protect patient data. We're still not doing a good job with it. We recognize that PCI had some technical control requirements. They threw in some lightweight technical control requirements as well as the fines. So that was the big thing. We will enforce it with a carrot, or excuse me, we'll enforce it with a stick and not a carrot, right? So here we are today. And they've got the proposed HIPAA security rule changes, 400 pages, right? And I think as many in the room would say, about time, right? So the world has evolved, right? We are no longer protecting healthcare from healthcare, although, you know, people would argue that we may be not as good as we could be, but we're much better than we were. But we're now protecting EPHI and healthcare networks from nation-state actors, organized crime, a whole different level of folks. So that's really what we want to do. So I've got Samantha Jacques with me here from McLaren. I'll let her introduce herself. And Stephen Goudreau from
Gigamon.
So Sam?
So hey everyone, I'm Dr. Sam Jacques. I am the Vice President for Clinical Engineering at McLaren, which is a 13-hospital system in Michigan. As my day job, I am also the Vice Chair of the Health Sector Coordinating Council, which is the public-private partnership between all of the health sector and the U.S. government. So that is a volunteer role for those of you that have nothing to do and want a third job on top of the 2 jobs you already have. You can come join HSCC with me. But I'm happy to talk about HIPAA, right, with my counterpart here, Stephen. So I'll let him introduce himself.
My name is Stephen Goudreau. I have almost 30 years in IT. I am a recovering engineer. I was a network engineer for a while, and then I spent over a decade at Tipping Point where I did some threat research. I also did operations in Austin for Ascension Healthcare. I replaced every network closet and every metro hospital that Seton Ascension has. So I've got some experience with what it's like on the ground for operations.
So this is great. So we've got an IT perspective, right? A compliance perspective. We've also got a med device perspective. Right, and I've realized, right, that today, right, much of, I mentioned before, 1.37 terabytes of data a day, much of that comes off of medical devices, and then we throw it across into the IT environment completely unregulated, right? What you have is what you're smart enough and can afford to negotiate for, right? So maybe Stephen, we'll start with you. Just what do you think, what are the highlights from 400 pages? Kind of distill that down to, these are what I see as top inspiring, if you will, changes.
So I did read through all 400 pages of the new proposed PCI 2025, not PCI, HIPAA. Funny you say PCI, because I find there's a lot of similarities between the two. It's just the data set that's special is different. I would say that HIPAA is about to potentially undergo a 60% expansion in technical controls. I've counted like 65 new areas, and section numbers are changing. So if you're familiar with the old HIPAA, some of the section numbers will be different. From an ivory tower security standpoint, it's good data governance, it's good security governance. Now, is it possible to get there overnight? Probably not. Is it aspirational? Maybe. But as you were pointing out, we live in a very different world. We have dedicated nation-state threat actors who are hunting for us. So it's no longer kids in the basement. Lazarus Group is financed by North Korea, who gets 40% of their take, right? So they're in behind a lot of this. Some of the key areas I saw in new HIPAA, which I hope stays, is inventory. You need to have an inventory of all your medical devices. They want a network map, but not a topology map. They want a map of all the PHI data flows. A third one is going to be all traffic should be encrypted, even if it's from internal to internal. And one of the last areas that I found a little surprising was that even if a device doesn't have PHI data on it, it could still be in HIPAA scope if it's patient care affecting. So that's probably up for interpretation. I see your hackles are rising there for that one. There's much more in it, but I think those are some of the key highlights.
Yeah, there's a lot in it. If you guys have not read it, I know there's probably 15 or 20 different articles that have been out about it that have tried to summarize it. It is 400 pages, and so I will tell you, any of the summary articles usually leave out one or two massive sections of it. So in addition to this, there's everything Stephen says is 100% correct. There's also huge sections on compliance, right? If you're in the compliance group with your organization, the attestation section is massive. I would highlight that the additional attestations that they are now recommending is onerous. In my opinion, and I will highlight everything with my opinion. The recommendations that come out with HIPAA pretty much indicate that from a risk-based perspective, it is now the hospital's responsibility to attest that every third party that you do business with and do a third-party risk assessment with is now your responsibility. So if you have a breach for that third party and you've done that risk assessment and they've attested that they are up to snuff and you didn't check it, it's your fault as a hospital, according to new HIPAA. And that's obviously a concern, right? So those of us that work on the hospital side and in the hospital organization, risk gets fostered on us on a daily basis, right? Because we're the end of the line. And it's a very troubling type of aspect. We don't have the resources to go ahead and do these attestations. I don't have auditors to send to every third party that I work with to go validate and verify that they're doing what they should be doing from a cyber perspective. And from a control compliance perspective, right, ensuring that my vendors are doing what they need to be doing is not my job. My job is to take care of a patient. And so that for me was one of the items that really gives me concern, I think, as I look through the 400-page document.
One of the areas where there's some cross-pollination with PCI is there's going to be potentially new ongoing reporting for compliance, right? At least every 12 months, you're going to have to run a report saying this particular thing is compliant. Let's talk about encryption. If you've got IoT that can't run modern encryption, you'll have to segment it, and then you'll have to run a report every 12 months showing that those guardrails are still in place. And part of the challenge is that healthcare is healthcare. They're not necessarily domain experts in security. On the other hand, we have electricity, but most of us aren't electricians, and we've got plumbing, and most of us aren't plumbers. So we're going to have to find some way to iteratively at least get out there and start to do this. And we talked earlier about some potential basic steps to get there.
No, and I agree. I think, fundamentally, we all understand that healthcare is not in a good place from a security perspective, right? None of us are where we want to be. And it has nothing to do with not wanting to get there, right? The ecosystem that the health sector is currently in is not something any one of us has designed, right? We've all happened into this environment because of a confluence of events that have occurred over the past 25 years, right? It is not something any one of us can fix, but we need to figure a way out of this. And I think that's part of what the bill was trying to do, right? It's trying to take a massive leap to get to a place to make it more secure. And there's pluses and minuses about it, right? You know, the timeline that's in there, right? The oversimplification of how easy it is to get there obviously is not something a lot of hospitals and healthcare systems can do. But aspirationally, we need to be more secure. I don't think anybody would disagree that the level of security, right, that we all need to get to has got to be better than what we're doing today.
So I wrote a paper on HIPAA, because apparently that's what I like to do, where I line item out. There's 4 pages where I line item out each and every new control. And there's a QR code over at my desk that you could scan and get a digital copy for free just to understand what it is. And I also map our capabilities to it, our network telemetry to it, just to start to give you an idea of how to accomplish some of these goals. Because when I was an engineer at Seton, I did network closet upgrades. And I'd have to make sure that 300 devices were in a closet. I had to make sure all 300 came back. So I had some experience on how to go out and find some of that. So there's some technology ways to do that probably aren't being leveraged today. And one of the other challenges we have is you have a bias for performance. You have a bias for uptime. Anything that impedes on that gets chucked out the window or is a secondary concern. So security solutions moving forward have to help enable that bias for uptime and can't necessarily introduce more friction. And that's going to be in the architect and IoT and manufacturer side of the house to help figure that out, right? Make sure your devices can have modern encryption, make sure they got modern management platforms, they may have a shiny front end, the back end's got to be just as new, and it has to be modular so you can update it. I would probably architecturally look at what they're doing with drones and compartmentalizing them and containerizing them. So if you breach any one section, the rest of the device still works, right? That's probably where I would start if I were an IoT manufacturer. But again, I'm speaking from the ivory tower threat researcher point of view. So there's lots of tactical problems along with that.
So I've always thought, and I've said this for a number of years, I'm a clinical engineer, for those that don't know me, and maintained all kinds of medical devices. You know, if you think about the FDA has over 560 product codes for software-enabled medical devices, right? And then you look at the IoT and the OT, the air conditioning, you know, the medical gas handling systems, the door closures and opening and access controls, you know, and that. And then you go through the traditional IT, you know, the diversity of technology in a healthcare environment is just amazing. And then layer on top of that, just the acuity levels. So the same device, you know, in different acuity levels has a different impact on the ability to deliver healthcare. And I think this is thematically the changes to the HIPAA security rule is really about ensuring that a healthcare organization understands what it has in its environment, what are the data flows that are critical to delivering patient care, right? And then identifying and protecting those that are most critical to doing it. So steps in the right direction for sure, you know, but it's not an easy thing to do at all.
No, and I would say, right, for those of you not aware, right, the HIPAA security rule has not passed, right? It is a proposed rule, right? We're anxiously awaiting any feedback from the government at this point. Comments were due this past March. I don't know how many of you actually submitted comments. Yeah, me too. But we're anxiously awaiting to see where it goes. There have been a lot of feedback on the way that the document was created, a lot of feedback on the content of the document. Fundamentally, I think, you know, we all have to agree, right? Like I said before, security is not a secondary thought, right? So from the medical device perspective, right, those of you that don't understand the way a medical device gets designed and developed and put into service, right, it is a years-long process, right? So it's not like your computer that has a, right, 8, 9, 10-month design, right, designed to sale kind of of path, right? Where I can actually get new technology, right, out the door in a reasonable amount of time. A normal medical device might have anywhere from 4 to 8 years before it actually hits the market. And so we have fundamental problems around, right, what operating system we deal with, right? Those of you that don't live, right, in my world, right, I have fights with manufacturers because I can't buy medical devices on a current Windows platform, period. Like today, it does not get sold with a supported Windows platform. How on earth are we going to create secure devices, secure networks, right, when I can't even buy something that fundamentally is supported, right? And so we have an ecosystem for which, right, the entire ecosystem is built in a way that doesn't allow support, right? And so it would be very difficult for me to just point at one portion of our ecosystem and say it's your fault. It's not, right? We are all in a very complicated ecosystem, right, that ensures that we provide care to our end user, right? If I would just point to my manufacturer and said, well, you've got to do better, right, their answer would be, well, then I'm not going to produce this, which means then I don't care for patients because I don't have a product, right? That can't be the answer, right? We all have to figure out a way to together, right, to secure and design and support our devices on an ongoing basis. And so that means we have some really unique ways, right, that we have to go ahead and find to work around these problems that we've created, right, in the years it's taken to get to the place that we are today.
We have a fundamental problem in not just healthcare, but in the tech industry as a whole. And that is the tech stack operates in layers. Upper layers don't know what bottom layers do, nor do they care. And they were never designed to run securely, right? The internet was designed to survive a nuclear war. It was not designed to operate securely. That means we have codified communication protocols that behave in a certain way. And if you poke it a certain way, it will respond a certain way. Without you knowing or without informing. And that's where we start seeing some of the bad guys moving throughout the network, phoning home. And now we have a new vector of attack, and that's where we're starting to see we can't trust medical IoTs manufactured in certain geographical locations. We found power inverters and batteries with cellular phone home and kill switches. So we're potentially one shooting away from half our IoT not turning on the next day because they're compromised and we don't necessarily know what supply chain software is in them. So that's another vector that we need to figure out. So step one is simply stopping the bleed, and that would be simply, right? And that would be stop having, now we know where all those Windows 95 boxes are, right?
Hopefully,
Yeah,
hopefully.
they're in the hospital.
Under somebody's desk, right?
Right. So
In the basement.
the first step would be stopping that and shipping up-to-date a product, and that's easier said than done, and that would stop the bleed. The next step would be simply knowing what you have, right? And there's some novel ways to do that, from top-down asset tag to bottom-up network telemetry, going, oh, there it is. So there's some ways in these codified protocols to find some of these IoTs through network time protocol, through DHCP options, and
Through
through other things.
microsegmentation we just talked about.
Microsegmentation, right. So
Right.
you can't do microsegmentation if you don't fully understand your PHI data flow map, because you're going to break it. So just running reconnaissance and knowing what you have is step one.
And then the other thing I would say, right, the other thing you really need to understand is you need a good governance group, right? You can't do this alone. Your organization cannot work in a silo. Your department, your IT department doesn't know everything. Your biomed department doesn't know everything. Your risk department doesn't know everything. Your compliance department doesn't know everything. Fundamentally, a good governance team, right, that looks at risk from an enterprise perspective is the only thing that is going to save you when it comes to identifying and stratifying your risk, prioritizing all of the things that we all have to deal with on a day-to-day basis, right? This HIPAA security rule proposed that's out has a laundry list of things we need to work on, right? None of us have enough money to do all of it. None of us have enough people to do all of it. None of us have enough anything to do all of it. We all need to start figuring out, though, what our priorities are, right? If you ask the CIO, his priority is going to be this, right? You ask me, it's going to be something else. You need a governance team to start answering those questions for you.
So reading through the Federal Registrar, I came up with 3 potential plans of attack when speaking to leadership at the C-level, right? The first one is regulatory fines. The Department of Health and Human Services Civil Rights Division runs HIPAA. We don't know what kind of stick they're going to have. That changes with every administration. So potentially being fined is one. The next one is breaches are now up to $10 million a breach, right? So just paying it off may after a while become more expensive. And the third one is it's mission affecting, right? A cyber incident has been shown to have negative measurable effects on patient health care. So either cost or risk or not being able to fulfill your mission, depending on who's leading, right? They may be more biased towards one than the other, probably cost. And there's some ways to measure and show that risk.
So it's interesting, right? And you mentioned the impact on healthcare because there's been some studies, and I think the very first one that I saw came out of Vanderbilt University, but it shows that if a hospital is breached, right, that the outcomes decline for a significant period of time, right? Most recently, the study that came out of UC San Diego was 18 months before we get back to where we were, which is a pretty long dip. The other study is that if a hospital gets breached, the other hospitals in the community are also impacted because they have to now absorb that extra patient flow. Right? So not just the entity that gets breached, the entire community is affected by this, and not affected just shortly, it's affected long term, right? So these are hard things to kind of wrap your head around, right? I mean, I think it's time to revamp HIPAA, right? There's certainly, if you looked through the comments, you mentioned the word onerous, and that was pretty much the theme of the comments was, how will we ever afford this? And we always think about hospitals and healthcare, and we think about the Ascensions of the world, the medium-sized groups, right? You've got to think that we're losing critical access facilities in our rural communities, way too fast. And much of healthcare is small, independent care providers. If we go back to Change Health, right, and the impact there, there were physicians that were mortgaging their house to make payroll till Change could figure out how to pay them for the services that they were submitting by paper or by fax machine. So it's a complex world that we live in. I think these are great states to do. So let's do this, right? Let's talk about, you mentioned the financial and operational things. So if you were to, let's say it went in as proposed, we know that's probably not likely the case, right? What do you think are the one or two things that you would say to your organization, we should prepare for this, or we should head in this direction?
Yeah, so number one, I think Stephen's already hit on, right? You cannot do security effectively without knowing what you have. So number one in my book is an inventory. If you don't have a clue on what you have, I don't even know how you begin to secure it, right? And so if your organizations haven't even started with what your inventory looks like, to me, that's the number one place that you need to start.
And I've got some suggestions on how to get there from a tactical standpoint, because I've done that kind of work before. It doesn't have to be as hard or as scary, and it could probably get you 80% of the way there, right? Because medical IoT kind of moves around. You've got Chronos time clocks, you've got those door badge readers, right? You have a lot more IoT than you think you do.
And this is a good point, right? When we say inventory, right, my IT geeks in the room, right, will think my laptops and my servers, okay? I don't care about your laptops and your servers because you push your updates to your laptops and your servers on a very regular basis. I am talking about every piece of medical equipment, every temperature sensor, right? Every game console that every physician has brought into their office, right? I am talking about everything that got hung on your network for the last 20 years. That is what you have to go find. And that is what is very, very scary once you start actually trying to identify what is this thing that's been talking on my network for the last 3 years that I don't even know what it is or what does it talk to. That's what you got to go find.
I've done that. I've stared at the wireless control system going, this is just a weird communication. It's been ongoing for 2 years straight. This is weird. I'm just going to block it and see if someone complains. Hope I didn't break something critical, right? And that was kind of the security side of me overwhelmed the operational side of me on that. But again, once we have that inventory, figuring out where your PHI data maps flow, they should be fairly static. So that's the good news once you have them, right? And if there's a delta, then you know something is amiss. And again, there are some tactical ways to accomplish that that probably aren't as difficult as you think. And that's using some of the network telemetry, because all these protocols talk, but they also have addresses and they're all unique. And they can be mapped back to manufacturers, and you can start identifying batches of devices no matter where they reside, even if they're not on your network, right? If a vendor has them, you may be able to see them.
And then I would say after that, and then you can start putting some security rules in place, right? From a high risk perspective. Once you understand what you have, right? You start putting stuff in buckets. What is super high risk, and what do you really need some rules around?
That would be the next thing. Like, what's your most special data? Once you have the PHI information, or once you have the PHI data flow, start with that special data, and then start to radiate outward, right? Don't try to solve everything. Simply say, oh, I've got to secure all DICOM. Period, in my organization. And then I'll worry about something else once we get there. Otherwise, you got to make it bite-sized, and it becomes too overwhelming.
So very good. Thank you so much.
Thank you, guys.
Thank you, everybody.